Welcome to Black Health Matters. I'm Daryl Armistead, your host. This episode is a Zoom recording of Howard University group session led by Dr. Clive Callender.
They have an interesting personal article by Francis Collins, who is the director, or was the director of the National Institute of Health for about 12 years, who now has prostate cancer. So he talked a lot about his diagnosis and how he's going to be treated to have a radical prostatectomy this month. And talked about how his diagnosis was made and how it runs in his family and how most men are going to have prostate hypertrophy or cancer at some point in their life if they live long enough. And how important it is to get the PSAs, which they've changed a lot. But for black men, it's still something that needs to be done.
Right.
He talks about how they were doing it for him well after he was after 70, and how that helped him making his diagnosis. So also an article there about Sean Elliott, a basketball player who had kidney disease and got a kidney transplant, and how he changed his diet and how his diet has helped him with his kidney transplant, and how he switched from being a meat eater to a predominantly plant protein diet, although he still eats some meat periodically, but mostly. Also talks about something we talked about last week in terms of the requiring of for hospitals to have informed consent for pelvic examinations. We talked about it last week. And all hospitals now are required to have that written consent forms for pelvic examinations. Talked about that. And then some of the new blood tests that actually give you an early diagnosis of cancers. And I think we have one in here that talks about an earlier diagnosis of ovarian cancer. And also about something that we talked about last week with hepatitis B, and hepatitis being the second leading infectious cause of death worldwide. It's a very rich section this week.
Yes.
So I recommend you looking at it. We have a plethora of articles, so I guess, John, we ought to begin, huh? Yeah, this is an interesting article. It's first opportunity to see that this gentleman who's got the transplant is black, who got the first transplanted pig kidney, and that he had a rejection episode that was reversed, so allowing him to leave the hospital and go home. So this is the first pig kidney transplant in a actual living person in history. So it talks a lot about the process by which they edited the pig kidney so that it doesn't have the viruses that it normally might have, and also doesn't have those rejection proteins that are normally found in the pig, which allow for him not to have the hyperacute rejection that usually was associated with xenotransplant. Hyperacute rejection means that within minutes to hours after you have the kidney is actually rejection that turns black. So that did not occur in him, but he did have a rejection episode, which was treated by immunosuppressive medications in order to reverse the rejection. And it was successful, so he was discharged and he's home now and doing well. And we're encouraged that this first transplant may be the beginning of something special. Of course, gonna have to wait and watch and see how he does. Uh, any questions or comments about this first pig kidney transplant to a living person? The two previous, for example, there have been four pig transplants, two heart transplants. Both of those patients died subsequently within a month or so. And there have been two uh, pig kidney transplants into patients who were brain dead, uh, just to see what impact it would have upon the, the human system. And then now this is the first for a live patient who actually had a transplant and actually is now off dialysis and is home. And whether or not this is the beginning of something special kind of depends upon how he does and when we'll do additional cases and then when they have a clinical trial, because right now it's experimental. Any comments or questions about this?
I had a question, Dr. Callender. So the other pig transplants were heart.
No. Two were heart for living patients.
Right.
And the two kidneys were patients who were deceased. I'm sorry, they were brain dead patients. They were brain dead patients. There were two kidneys, but they were in the brain dead patients, so they were not living patients. So this is the first one in living patients. So actually, that this will be the fifth pig transplant. Two hearts, two kidneys, three kidneys, but only one to a live person who was transplanted and is actually discharged and went home.
My question would be, is there a possibility of a liver transplant from a pig?
Oh yeah, there's possibilities, but it hasn't been worked at yet. Once I think that the real job will be to see how this works with this patient, and then do others, and then have a clinical trial to see whether this is worth doing. And then if this works in kidneys, then it could be uh, expanded to livers. Livers is, of course, the largest organ we have, and so it's probably more complex. But I think the goal is first to see if it works with the kidney. Any other comments or questions about this alarming development, which may help us with the number one problem in transplantation being the shortage of donors? Okay, if there are no more questions, we'll go to the next one. This is a bizarre article which talks about a surgeon who was well known for his work, who is alleged to modifying things on the computer so that his patients don't get transplants, which is shocking. But this is what they accuse him of, that so much so that they shut down his program while they're looking into the accusations. Whether this is accurate or not, the fact is that when they initially looked into the computer, they did find evidence that he'd modified some of the details so that those patients would not get the liver transplant. But time will tell. Often accusations are found not to be so. So it's possible this is not the case. But the early investigation was very suggestive that he had done things that kept patients from getting transplants. It's the only instance I know of where somebody has been accused of, where a surgeon has been accused of doing this.
Why? What?
Mental illness.
I'm sorry?
I was wondering why. What did he gain from denying life or health?
I guess you'll have to tell us that after the investigation is over.
Good.
There was no clue as to
Mm.
why he decided to do that, but after the investigation, I'm sure we'll find out. Of course, it's the antithesis of what his career is all about. But
Mm.
Do they have anything to do with race?
we don't know anything. We don't know any answers. So we have to wait and find out what the investigation discloses.
To me, it would be almost impossible to determine that somebody changed numbers unless they had the original document, and then
Oh, well, it's easy to find out because all of this is on the computer.
Mm.
Any change you make is on the computer, so it's there. So it's easy to find out. If he did it, it will be evident to everyone. The only thing will remain is why he did it. But whether he did it or not is easy to ascertain because everything is on a computer. You have to respond to the computer request, and that request is there forever. So they'll be able to track it and find out. Now the next issue is the answer to Stevenson's question. Now that is Janice's question. Why did he do it? Yeah.
Crazy.
So time will tell. Probably by next week or thereafter. This occurred in Houston, which is one of the busiest transplant programs in the country, where they do many liver transplants.
Dr. Callender, one question that begs is making these changes on the computer, like they said in the article. He put in a toddler was 300 pounds. And so my question is, when they're doing the screening to see if a person qualifies for a liver transplant, then somebody is putting that information in. And let's say, just as an example, let's say.
Well, nobody put it in. Let's be clear. Nobody put it in until he put it in. So it didn't exist until he put it in.
Yeah, okay. Well, that leads to another question. Somebody is verifying. In other words, when they do the screening and they put in those numbers, somebody goes
This
back.
is not screening. You gotta understand. This is not screening. This is when an organ becomes available for a patient. You have to respond and indicate, yes, I will accept the organ, or no, I will not accept the organ, and this is the reason why. So it's not screening. This is where you've already listed the patient, and then indicates that we have an organ that is for your patient. You then respond with, my patient is ready and willing, or my patient is not ready because of, and so forth and so on. So it has nothing to do with screening. It has to do with the surgeon actually responding to the availability of an organ.
And you're speaking of one person responding.
Of the transplant surgeon or the transplant center responding.
Okay. That leads to the other question. Either it was one person responding to the availability of that organ, or it is the center, the whole transplant center responding.
In this case, it was the transplant surgeon.
Okay, well, and this is a final question. That should lead to me to believe that it should not be one person to respond to an availability of an organ.
I don't agree. It should be a person, but that person should have integrity. It has always been a person.
A
But
person.
it's expected that that person has integrity. This person did so, but we will have to learn and understand why he did that. But it has always been the case that one person can do it. And we have people, it's just like you have good doctors, you have bad doctors, you have good teachers, you have bad teachers, you have good lawyers, you have bad lawyers, and one bad apple doesn't make all the apples bad. And so now the question may be, and I think this is maybe what you're thinking, that in the future, you may have more than one person involved in that. But so far, that process involves the transplant surgeon. And the transplant surgeon in the past has been expected to do what is in the best interest of the patient. And that's why this is so irregular, because this is an instance in which he did just the opposite.
Right. Well, I think you answered my question there because in the future, maybe a team of doctors can respond to the availability of an organ.
Well, that's not the case right now, and I'm not sure that it needs to be. But it's food for thought, because if you have one person who's doing this, it makes you wonder if if there's more than one person that is doing it. Right now, it's the person that the transplant center designates is the person who accepts or rejects the organ. Any other comments or questions about this unusual occurrence?
I know, Dr. Callender, that this was a issue that you stood up for in terms of making availability of organs to meet the needs of our community. And I understand the importance of the integrity of the surgeon, because somebody has to be responsible. And I'm assuming that that responsibility would fall to the surgeon who would be responsible for the operation. So it's important, like we're meeting now, to raise the understanding of how important it is for a comprehensive look at those who would be eligible for transplantation. We used to say that if you were still drinking, or if you drank within 6 months or something like that, you were ineligible for transplantation. We used to believe, like for my mother, who was a diabetic, that we didn't transplant diabetics who were in renal failure. So increasing the availability or the eligibility of populations that, because of social or economic reasons, weren't even eligible. I think it's important that voices like yours, those who can see the importance of opening up this level of scientific technology to everybody.
Well, I think that's a good point, and I think what Mr. Tatum is suggesting is that after you look at after you do that, take that comprehensive look, if you ascertain that this is more than just one person's behavior, that maybe we need to change the process. And that's what Mr. Tatum is suggesting, is that the process should be open to more than one person. And it actually is open, but people have believed in the integrity of the transplant surgeon, and as such, if the transplant surgeon has made the decision, many of the people would then presume that he's done it for medical reasons. And so if a comprehensive look at this identifies that there are surgeons who are manipulating the system for whatever the reason, then Mr. Tatum's recommendation may have to be followed. Any other comments?
Here. I agree.
Yeah. Any other comments? If not, we'll move on and await what comes next in that fascinating case, because I'm afraid that they may validate Mr. Tatum's concern, but we shall see. This is a fascinating article because it talks about what actually we've talked about for some time, that stem cell transplantation, xenotransplantation, and regenerative medicine are the future. I give a lecture probably once a month on transplantation and talk about Ponce de Leon, who was looked for the fountain of youth. And in transplantation, we actually looking for trying ways to stay alive. And so one of the ways is, of course, the kidney organ transplants, and the other is regenerating organs, and the other is stem cell transplantation. And of course, the umbilical cord is the source of many stem cells. And so taking this and using the stem cells from the umbilicus and using them for regeneration of the cardiac cells is something that is being done across the world, in France and other places. And umbilical cord is a great place to identify myocardial as well as pericardial stem cells. And so this then is what is being done in some circles, and down the road, stem cell transplantation may well be the answer to the fact that the number one cause of death in the world is heart disease. And this may be one of the ways in which we get to getting heart, pericardial cells, and myocardial cells to be regenerating. And instead of spending so much money in the ICU, we will just be able to inject stem cells into the coronary artery and get them to regenerate. Mr. Buchanan.
My question is specificity. How would you determine which types of cells are going to benefit from this, that would actually regenerate? How can they specify pericardial?
Well, for the most part, stem cells, the stem cells that are found in the umbilical cord, are generally the cells that can be changed to be pericardial or myocardial or other cells. And so, and we also have a process that is able to transform some stem cells into organ-specific cells. And
Yeah,
so that's the process that you're asking about, which is being worked on now.
okay.
Because down the road, if you can get myocardial cells to regenerate, then you could take care of the heart attacks and the heart problems. And for example, if you had the same thing in the pancreas, you could wipe out diabetes. And so that for example, some work has been done that transforms squamous cells into stem cells that actually can be transformed, because there's stem cells that can be transformed into other specific organ-specific tissue. And that's the process that is being worked on with the expectation that these umbilical cord stem cells can be transformed into cardiocytes, the pancreatic stem cells, and that's the real job, to try to identify how you can make these mesenchymal stem cells transform to the organ-specific cells that you want.
Okay, thank you.
Dr. Callender, my question is the umbilical stem cells. What's the source of those? Is that a live fetus or dead fetus?
Yeah, this would be a fetus. In other words, you would get, yes, it would have to be a fetus, and there would be a live fetus, because, in other words, when you deliver, of course, the umbilical cord is cut, and from that umbilical cord comes the stem cells.
Okay, so in other words, baby is born, you cut the umbilical cord, but then you use it as a source for stem cells therapy.
That's correct. Now,
Okay,
as you may know, that early on, that process was stopped because of the concern about using the fetus. We now have identified ways of actually transforming squamous cells into stem cells. But the original and the ideal source was actually the umbilical cord and the stem cells that you got from the umbilicus.
But to that point, Dr. Callender, wouldn't you say that the political, not scientific, but the political conversation as it relates to life, abortion, things of that nature, influence and impede science moving forward, utilizing this method, correct?
Yeah, so yeah, as a matter of fact, there was a ban on using umbilical stem cells because of that, and that's why a lot of the work was done outside of the United States, because in the United States it was prohibited.
That's why voting is so very important, even for everything that we're talking about, because we would not want a political outcome from something that is purely scientific.
Well, of course, one of the most important concepts to keep in mind is that as we increase our technological skills, the community must be involved. Otherwise, what happens is that what the technological feats are then used only for the very rich, and the very poor are eliminated. So for that reason, the community needs to be involved in all of the newest and the brightest technological improvements, so that we don't get things going the wrong way. Because what we're trying to do is to reduce the majority-minority disparity. And with the community involved, that majority-minority disparity is narrowed. But if the community is not involved, then all of the technological advances will go to those who are very rich, and the rest of us will be left out. So this is an important concept to keep in mind.
My concern is the level of understanding or intelligence of the community.
I don't worry about that, because it's, you know, the job is not whether we can do something. The real issue is whether we should do something, and that's where the community should play a role. And you're right. There's certain technical aspects of it that are critical, but the community needs to weigh in on when we should and when we should not. And that's the aspect of it that, regardless of the technical aspect of it, the community, as far as I'm concerned, must be involved.
Dr. Callender,
Yes.
I question we have we have a plague of moral bankruptcy in our society, and that's what bothers me.
It should bother you. And that's why the community needs to be involved to protect against that moral bankruptcy. And that's why I take a strong position that the community needs to be involved in everything we're doing. Because you're right, we do have moral bankruptcy. And if the community is not going to keep us honest, we won't be honest. The rich will get richer and the poor will get poorer. Any other comments about this very interesting?
Dr. Callender, I agree with John Buchanan in a way about education, because who has the most money and the loudest voice will society believe? So if the ignoramuses come up there with the loudest voice and they have the most money to persuade your way, then someone that is not in medicine and can't really understand what's going on, that politically they are at a loss and they'll just go with what is ever being told to them how to vote.
Well,
Because
they shouldn't represent us then. The person who represents us has to represent us. And if that person does not represent us, we're in bad shape. But your points are well taken. It's just that we have a responsibility. For example, if I, as an African-American transplant surgeon, didn't represent us in the transplant arena, then we wouldn't have made the progress that we made. So when we have a representation as a community person, we have to take that very seriously. Otherwise, the moral bankruptcy that you speak of will continue and will not be abated. But there's no question that what you said is true, that's a potential hazard. But it's something that we must battle for and not give up on.
And that's why we thank you for representing us with such integrity. You elevated everybody. Thank you.
Thanks for being my PR person.
Thank you, Dr. Callender.
Okay. Any other questions or comments about this very avant-garde issue? But I'm just bringing it to your attention. So as it's just like when we first brought to attention gene editing, and now lo and behold, that's the state of the art, and everybody talking about it. We talked about this about 5, 6, 7 years ago, and now it's the state of the art. And soon, so will be stem cell and regenerative medicine and all of those things that we talk about glibly today, which will be 10 years from now. That will be the state of the art. Okay, next one. Now this is we talked about ovarian cancer last week, and the fact that making the diagnosis often was difficult because we didn't have blood tests that would really help you. And so now this is a new blood test that actually can be a screen for ovarian cancer, and it shows promising results. Because as was mentioned last week, many people who have early forms of ovarian cancer are missed because the signs and symptoms are not specific. It can have increased abdominal girth, or you can have non-specific signs. And so since we had no test in the past, many of those patients in the early form of ovarian cancer were missed and not diagnosed until it was too late for them to be treated in a meaningful way. This test has the potential of identifying stage 1 ovarian cancer much earlier than any other test so far. So it's going to take time, but it's nice to see that we're moving in the direction of getting a test that will allow for an early diagnosis of ovarian cancer. That's what this article is all about.
Dr. Callender, I wanted to ask a question about a previous article today. The doctor who was the director of the NIH.
Francis Collins, right.
Yeah. And, the statement that was made is that prostate cancer is inevitable if you live long enough. And
Correct.
so the question is, where does early diagnosis play a part in that?
Well, okay. One of the things that if you read, I don't know if you read the story, but if you read the story, it shows that what happened, he had prostate cancer that was not, seemed to be pretty passive and not very aggressive. But his PSA elevated from 5 to 22. And that elevation of PSA meant that they needed to do a biopsy and find out if his prostate cancer had transformed from passive to being very aggressive. And in point of fact, that's what they identified, that it had transformed to be a very aggressive cancer, and that's why he's having a prostatic cancer surgery this month. Does that answer your question?
It does. Thank you.
Any other comments or questions? If not, we'll go to the next article. This is an interesting new development that radiation before mastectomy decreases the delay for reconstructive surgery in breast cancer patients. And many people always thought you had to wait until you did the mastectomy before you did the radiation. Now, and that was felt that radiation would delay everything. Now we're finding out, based upon this work, MD Anderson, that doing it first actually speeds up the ability to do the immediate breast reconstruction. So this is a remarkable finding that will make it easier for women to have an immediate reconstruction of their breasts after having their breasts removed for cancer. So this is, it's interesting. As we go, it goes back to Carol's comment that the community person may not have known or understood this, but it was the expectation that the people in the group would break it down so that the community people could understand what is meant by this, because that is the responsibility of the scientists to bring it down to the level that the community people can understand how it can impact them in their future and the rest of the community. So that's an obligation and responsibility that we as scientists have to make it clear and break it down. Sometimes we don't do a good enough job, but we certainly should. Any comment about this spectacular finding that will make the ability to have immediate reconstruction of breast after breast cancer surgery?
I think it points to the fact that the priority of breast reconstruction is probably felt more by women than by men. And
No question.
having female physician scientists involved, how important it is that we have diversity, equity, and inclusion.
Yep.
No matter how hard they fight against it. And they are fighting against it. But we have to fight back.
Right.
Yep, it started in the Garden of Eden.
Yeah, the Republicans are fighting it desperately right now. And the worst is yet to come. Now, this is something that I want to point out, that maternal mortality is horrifying. And we are, while we're a country that is rich, we have some of the poorest maternal mortality rates in the world. And so this is something that we need to spend much more time working on, because you can see here that Black women are 3 times more likely to die from pregnancy-related causes than many other ethnic groups. And of course, Native American women is in the same category, and to some extent, Latino Hispanics as well. But it's something that we have to be part of the solution to the problem, because our women are dying at a terribly high rate. We just had a Kansas City football player's wife die after delivering a baby, and you know what happened with Serena Williams and other Black women as well. So that we need to really focus on maternal mortality. And one of the best things to do as soon as you identified as pregnant, to start getting your, your maternal health taken care of. Any other comments about this disease that is rampant in the United States, and more so than other developed countries? Any comments about it, as your daughters are prime candidates and granddaughters are prime candidates for this? Okay, no comment. Well, this is something that I guess is no surprise, but sexual harassment rates remain high among women in medicine. Every study that I've ever seen demonstrates the same thing. The question is, what else can we do? Dr. Perez, you got any thoughts? How was your experience coming in? Well, maybe Dr. Perez has left. But this is a problem that ever since medical schools have become predominantly female, the issue of 2 things have emerged. One is that sexual harassment has continued to accelerate. And number 2, the ceiling for women in medicine has still not allowed them to get into the highest positions that you would want them to be into. And so this is something that in medicine, having more women in medicine will help us decrease the amount of harassment. But so far, it still remains a huge problem.
Dr. Callender, one thing I found interesting about this article was the different names that they have here under the heading of sexual harassment, gender harassment, unwanted sexual attention, and sexual coercion.
Yeah, yeah. The same disease, it's just different names.
And does it involve having to do with, let's see, how do I ask this? Asking for a date. is on one side of the fence, just asking for a date. And the other side of the fence, does it have anything to do with what you might call the glass ceiling?
Yeah, that's what I said. Maybe I didn't make it clear, but the glass ceiling is ever present. You don't find very many women at the top of the field of medicine. And asking for a date is not the same as sexual harassment. Asking for a date is okay, but what happens after you ask for a date and she says no? See, that's when the harassment begins.
Well, then I won't give you that promotion that you
Right,
asked for.
that's right, and it goes on and on, and so that's the beginning of it, asking for a date, but the rest follows, and the glass ceiling is there. Uh, but the more women we have in medicine, I think that's one of the solutions, to have more women in medicine and to have them continue to complain and get men to change their behavior.
Is this about instructors harassing female medical students?
Say again?
Is this about instructors harassing female medical students?
No, but more about uh, doctors harassing interns and residents because they're the lower part. The medical students have their protectors, but once they leave the medical school, they become interns and residents. Then it probably starts with them there, and is unending from that point on.
Dr. Callender, I had a question. I don't know if it's directly related, but I was just wondering, in some Muslim countries, are there any female doctors at all?
Yes, there are. As a
So
matter of fact,
how do they get through that? Because it's structured, so structured, male on top of everything.
yeah. Well, for example, Pakistan is a Muslim country, and they have a large number of female doctors. So I don't know how they get through that system, but they do, and they have a significant number of female doctors that we train. For example, at our hospital, who've come from the Aga Khan University, which is the premier medical college in Pakistan.
What about Afghanistan? That's what I was really thinking of.
I don't know about Afghanistan. I do know about Pakistan, but I don't know about Afghanistan. I don't know a lot about India. Uh, so, but it is clear that the gender issue is a significant one in Muslim countries. Okay, if there are no more comments, go to the next one. This is an interesting article that points out that when we have heated days, that this causes kidney failure to the kidney capacity to decline, particularly in patients who have chronic kidney disease. So that the heat is not good for kidney patients, and that if you have kidney disease and it gets hot, that you need to uh, take advantage of the air conditioning. That's what it's. That's what this article is suggesting. That as the temperature goes up, the kidney function goes down, and so when it gets up to 100 degrees and all that, the macho thing is to go out in it. But the protective thing, if you got a kidney disease, is to stay in the cool. And that's what this article is really all about, that the heat, everything goes up, but your kidney function goes down.
So, Dr. Callender, that EGFR, that's the kidney function?
Yes,
Okay.
yes. In other words, you'd like the kidney function to be at 100%, but it would be dropping as the heat goes up. And when you get to 20% or below, then you're at the point where you have to be on dialysis or get a transplant. Any comments or questions about this article? Okay, next one. Now, this is an article that we've talked about before, but we didn't ask the question. How many of you have tested your homes for radon exposure? Any of you?
We had ours tested before we bought the house, but not since.
Well, that's good. That's good. And how about anybody else have their house tested for radon?
Yeah, I bought a house in 2004. It was tested for radon. It passed the test, so we moved in. And then in 2019, sold the house, and it had a radon problem that we had to be remediated. So that was living in the house for 15 years. During a portion of that time, it had a radon problem, and I was in the basement soaking up the radon and unaware of it.
It's a concern that most of us, as you mentioned, are not aware of, and it's something that is a cause of cancers, and so it's something that myself included, all of us need to get our homes tested for radon. As we
They make
talk about, go ahead, yeah.
Yeah, they make radon detectors. I think the cost is about $300 or $400, just like a carbon monoxide or carbon dioxide detector, where the alarm will go off if your levels are too high.
So I wonder how many of us have radon screens. I don't, and so that's food for thought.
It is. You would have to go into business if you paid that much for a radar. You have to go do other people's houses for them and get your money back.
But it's not a testing device, it's a permanently installed device.
So it costs about $200-300 Darryl?
Yeah, you had let's see, sometime this year, I think we talked about radon. And after we did, I went on Amazon to see what a radon detection alarm was. And I saw the price, $300 to $400. And that's when I changed my mind about buying one. Because I've just been in this house for a couple of years, and I said, well, it's tested 2 years ago, so I'm safe. I'll wait until another couple of years when the foundation shifts, and then I'll get that radon detector.
Well,
By
okay.
that time, it'll be $600.
That's called penny wise and pound foolish.
Right.
Anybody
Dr.
else? Yes,
Callender.
yes.
I'm always hesitant to do things like that, like get somebody to come in and test, because I remember one time when something happened to my car, and this mechanic told me something, and my father always told me, if somebody tells you something is wrong with your car and that you need this immediately, tell them you're going to talk to your father about it and see what happens. And I would say that to mechanics over the years, and they would say, oh, well, you probably could be all right, but if it's a thing of they're going to give you what your perceived need is and not what your real need is. So I'm always afraid I'll be prey to someone else's scam or scandal.
Well, if you if you test the radon yourself,
Right.
then
Right.
you would be prone for that.
Right.
But most of us have not even thought about testing. So because and all of the studies point to the incidence of cancer increasing all over the globe, and so since it comes from below, it's something that I'm going to talk to my my wife about seeing if we can get it done because we've been in this house for 40 years and never thought about radon testing.
So I counted my stepmother died from lung cancer and never smoked a day in her life. So that made me think that it could have possibly have been related to radon.
Mhm.
Okay,
about
I'm on Amazon right now, and there's a radon detector where you just it's battery operated. You just test your house, turn it back off, um, and it's $134. There's a permanently installed monitor for $300 on Amazon.
Oh, okay.
That's good to know. Thank you, Daryl.
Mm-hmm.
John, your stepmother wasn't subjected to secondhand smoke, was she?
Not at all.
Okay, well, let's go to the next one. That's an alarm I think it's important for us to raise. This is an interesting article about a CPAP alternative may be better for lowering your blood pressure if you have hypertension. And this is a technique of mandibular advancement devices for patients with obstructive sleep apnea, which is due to mandibular issues. And they are saying that this is better for lowering the blood pressure than CPAP. And one of the things is clear that CPAP does lower the blood pressure. So this then is something that people who can be made better by repositioning the lower jaw. This is something that is an alternative for people, although CPAP does lower the blood pressure. And knowing other ways of doing. We talked about Inspire a couple of weeks ago, and now this is something else, but this is specifically for lowering the blood pressure.
I thought CPAP was for make you stop snoring and make your breathing
Yeah, but most people aren't aware of the fact that most people who have obstructive sleep apnea also are hypertensive, and the CPAP is a treatment for that hypertension as well, because the acidosis that results from the obstructive sleep apnea actually causes hypertension as well, and that's one of the important consequences of CPAP is that it normalizes the blood pressure as well.
CPAP is the gold standard.
Still the gold standard.
This mandibular advancement that moves your lower jaw forward, so it kind of opens up in the sinuses.
Well, it opens up your breathing, not so much the sinuses, but your ability and keep the tongue from obstructing your airway.
So can you still snore?
Well, you should snore less. Let's put it that way.
You can get plastic surgery and do it permanently.
Who wants surgery?
Especially plastic surgery.
Okay, let's go to the next article. Are e-cigarettes bad for the heart? And of course, the answer is yes, they are just as bad as cigarettes. And this is a study that, although it's a small study, and that's what's the problem with this, is it's a small study, but and it's not a study that involved people of color. but I did find that the vascularity and the arteriosclerosis was similar to the arteriosclerosis that you get from smoking. And the more evidence that we get that e-cigarettes are not harmless. Some people thought that e-cigarettes would be the answer. You could still smoke, but and not get arteriosclerosis and all the other consequences. But so far, the studies are indicating that the effects on the heart are essentially the same as that of nicotine. Of course, these studies are small numbers, and it would be better if we had huge numbers and also numbers of people smoking in our country. Any of you do e-smoking? Vaping, as they call it? Okay, well, so tell your children and grandchildren that no smoking and no e-smoking.
Yeah, right.
They won't listen to you anyway, huh?
A lot easier said than done.
But you have to say it.
Yeah, I think you
You
should.
have to say it. You have to say, listen, children, do not put your hand in a fire.
Well, if you put their hands in the fire, then you don't have to tell them that. That's what my father did to me.
If
Must
you
have
don't
one
say it,
too.
then later on you can't say I told you so.
They also mentioned hookah. You know, that's a big thing at some of the clubs I play at. You know, they have you go in the back and pay some money to puff on this hookah thing. And I have no idea what's that about. Is that tobacco or what's happening there?
Vaping is a group vaping. That's what that is.
Or what do they put in it? What are they actually smoking?
Tobacco.
It is tobacco.
Yeah, it's tobacco. It's legal. I guess you're ingesting it in your lungs and stuff. I thought it was hooker at first when they told me it was hookah. But, I don't, yeah. And you see these machines where they all had the thing going into this one pipe, the old fashioned pipe that I don't know anything about.
They sit around in a circle, and each one
John
takes.
doesn't know anything about it, but anyway.
They do sit around in a circle.
How do you know?
Well, Dr. Callender said, tell your grandchildren and your children not to do it.
Yeah. Okay, let's go to the next one. This is a problem that we've noticed in the hospitals, that as it says, hundreds of drugs in short supply. I often wondered if it was more like thousands, but all types of drugs have been short in the hospitals. And I'm not sure why, but I do know that this is a shortage that is affecting virtually all aspects of medicine. And I'm not sure as to the reason, but it is a fact that most of the drugs are the hospitals are in the hospital. There's a shortage of most drugs. And why they don't answer in this article either. But many of the drugs that we use, we have to find alternatives because of the shortage of the supply of drugs.
Okay, I just did a search on reasons why for the drug shortage, and it says it's a function of brittle market structure. Nearly half of all generic drugs have a single manufacturer. And okay, so you get supply chain problems, um, uh, quality problems, delays. But when there's drug shortages, it leads to higher drug prices. So it almost seems kind of wicked. You got a few drug companies in charge of most of the manufacturers. They create a shortage to drive up prices.
Yeah.
Mhm.
So it's a shortage that's intentional of money.
You would think
Mhm.
Yeah.
because they have to work less for greater profits.
Mm.
Also think Adderall is being abused as well. It's sort of like speed, I think.
Mm.
That's
Mm.
that's not related to the shortage, though. Wow. Oh,
I think so.
Okay, any other comments about that? If not, this is something we talked about before as well, but I think it's evident as we had a video that showed that AI can actually help you be a better doctor
Mm.
in many ways. And I think doctors shouldn't be concerned. They should be educated so they can use AI so that patients be served best.
Unknown caller.
What's that?
John, could you go back to the top of the name of the article for a minute?
Are you ready for my answer? But yes, I'd like to utilize it to help me be the best doctor I could be because it's clear that in almost every area of medicine, AI can be helpful. So it shouldn't be. I'm not interested in the competition. I'm interested in working along with AI so we can do what is the best interest of patient care.
Yeah,
And
I
I think that's the attitude that should be taken.
yeah, I looked at that title, and what came to my mind was this issue of a second opinion. Um, I agree that yeah, doctors can work side by side with AI, but for AI to be taking your regular doctor's place, that's a different question.
Right, and I don't think that's the AI can take your doctor's place, but I think it can supplement and be additive to what your doctor can do for you. But it's it, and I think that's the position that most doctors should take. That AI can help me be the best doctor I can be.
Yeah, because this article points to doctors. That question is for doctors right there. That question at the top.
And that's why I gave the answer. I'm not going to be in competition with AI. I'm going to use it to help me be the best that I can be.
I sent a few of y'all an article that AI did about vitamin D3. Did you get that article, Dr. Callender?
No.
Okay. Yeah, we had a question about um, vitamin D3.
Oh, that one. Yeah. Oh, did I get that? Yes. And I thought it was an excellent article,
Yeah,
and I think we should share it because the mechanism by which I think John Buchanan asked the question originally. Uh, why? How does sunlight help you synthesize vitamin D.
Right.
And the article identifies the ways in which the steps by which vitamin D is metabolized as a consequence of the sun.
Right. And so that article was provided by AI.
Right. Okay. And I think AI is a great additive to us as physicians in every aspect of us. All we do. And to have a competition is a problem because there's no competition because the AI is an excellent tool.
Same thing in chess too. You're not gonna beat AI in chess. I can tell you that.
Really?
No.
I didn't know that. I didn't know.
Yeah. Matter of fact, the best human played the best machine, and they ended up with a tie. So,
Really?
yeah, you're not gonna beat it. It's just end up with a tie. That's the most you're gonna get.
That's the best you can do is tie, huh?
Mhm.
Uh, well, you know, I think the one thing AI cannot do is to do a physical examination. And so it can look at x-rays. And one of the problems I have is that so many doctors now want to get x-rays and don't do physical examination. And I think the two together are unbeatable, but I think it doesn't replace the physical examination. It supplements the physical examination. Can the robot be taught to be empathetic? I don't know, but it's certainly a trait that is part of the art of the practice of medicine. The ones that use the tools the best will be the best. And that's a great idea to use it as supportive, not competitive.
I really think anytime something new comes out, there's going to be controversy about it and whether to or not to. And I think the person using it really has to be the judge as to how much they want to use it or not.
And I like the end where he says, my purpose not to replace you. My purpose is to be supportive and enhance your ability. And that to me is where AI plays its greatest role.
Yeah, the only real issue though is when AI becomes self-aware and replaces fires you and takes your place.
Okay.
I'm better than you, so I'm going to take your place.
Yeah, that's what all of the movies that they have.
Very scary.
Yeah, that's what's scary about it. Yeah.
They have movies out about that.
Oh, of course. Yeah, all of them. Now we talked about the bird flu last week and the fact that the person had tested positive and as a consequence, because of this and the fact that we don't have antibodies to the avian flu, the CDC is recommending all states become sensitive to this. Whether this has happened or not, this is what the CDC is asking. Since we do not have antibodies or vaccinations for it. So So since it's gotten to the cows, there's a fear that it get into the milk and so forth. So that's why they're asking all states to look into this.
So would pasteurization get rid of this virus?
I don't know the answer to that question. That's a good question. I don't know the answer to that.
Usually, pasteurization gets rid of the bacterial portion, but
That's correct.
the
I
viral.
don't know about whether this specific virus is treated by pasteurization. I don't know the answer to that question, so we'll have to research that. Now, this is another virus that some of us have probably already have and didn't know about it. But what's different about this virus is that this is not the one that's airborne, and it's not one that hand sterilization is effective. It's one of them where masking doesn't help, and hand washing does, and sterilizing surfaces does. And when you get to person, when they vomit, stool, or get the virus on surfaces, which food and water can spread, associated with diarrhea and vomiting. Um, uh, any of you ever have GIs where you vomit and have diarrhea? This is the virus that is thought to be responsible for much of that.
I had something like that with food poisoning, I think.
Yeah,
That'd be
yeah,
different.
yeah, and that's the virus that does that. Not killed by hand sanitizer. Controlled by hand washing with soap and water. Good old soap and water, huh? Okay, let's go to the next one. To no surprise, salt substitutes reduce mortality from cardiovascular events. We do know that many of the salt substitutes are potassium. And so for kidney patients, it's you have to be careful with it because potassium in some kidney patients can be lethal. But it is clear that salt is not good for us, especially us, and it's associated with increased risk for mortality from cardiovascular disease. And so it is recommended. Anybody against salt substitutes?
To me, they don't do the same thing. No, I'm thinking sugar. No,
No.
really use salt substitute. I was thinking about sugar substitute.
Which is different, yeah.
Yeah.
Okay.
You know, Morton is a big salt manufacturer, but they make Morton salt substitute, so you can buy that in most grocery stores.
And they have their cake and eat it too, huh?
I gave up salt for Lent. I haven't gone back to it yet, so I'm shaking it on stuff. So I'm trying to keep away from salt shakers.
Good idea. Good idea. Let's go to the next one. We're getting close to 10:30. Salt and sugar are our enemies. I've never really liked much salt, but I love sugar. There was a time when people thought Tylenol was related to autism and adult DHD. And this is a study that looked at 185,000 children and found no relationship between autism and ADHD and Tylenol. So those who take Tylenol for headaches and such need not worry about it any longer, according to this study. Now let's go to the next one. This is not surprising, but anxiety and depression may accelerate heart disease risk, especially for young women. And so it becomes important to know how to deal with anxiety and depression because they're so common, and we have so many stresses, especially with our complexions. And so knowing how to treat hypertension and how to de-stress becomes an important. Knowing how to exercise, how to meditate becomes very critical particularly for younger women. We talked many times about the way to keep your blood pressure controlled, and we've talked much about the way in which we can de-stress ourselves. And so this is apparently more important for young women than it is for older women.
That might, do you think that could be related to who was sampled and how?
Say again, who, what?
Who was sampled and how? Saying that
Well,
this
I
is
think
more. Go ahead.
I think yes. It would help to know what type of women they're talking about, and that's one of the issues in most studies. Who are you studying? Are you talking to people of color, people who are not of color, Native Americans, Latino Hispanics? Who are you talking to? And they don't identify that in that article. Along those lines, this is an article that says that chilling out rather than blowing off steam is a better way to manage anger. Chilling out, and they show guys chilling out by boxing and other ways to chill out. But blowing off your steam apparently is not as healthy as chilling out. Deep breathing and those and do yoga, meditation, and mindfulness, recognize the importance of that aspect of it. And then, of course, exercising, jogging, and other things are better. Screaming into your pillow or pounding on a punching bag.
Dr. Callender, has it ever been necessary for you to tell somebody to chill out?
No, because no, so no. Well, I guess with my daughter, sometimes she acts out. That's my only person. Did it work? No, but I advised it nonetheless. But, yeah, when people get upset, uh, sometimes it's you may as well not tell them to chill out because they don't pay any attention anyway. But it is clear that controlling yourself is better than blowing off steam.
Mhm. Just
My
walk
mother
away.
used, go ahead.
Mhm.
What's that, Lucia?
My mother gave me an opportunity to meditate and chill out when she told me the spanking was coming.
Yeah. Okay, Carol. Have a good session and let them cry. Let them cry. uh,
Stop telling me to chill out, Carol.
we studied this. We talked about this in the previous study that specific gut bacteria was linked to Alzheimer's, and the truth of the matter is, the more we find out the connections between Alzheimer's, the less we know how to treat it. And I'm at a loss to really understand why we talk so much about taking care of Alzheimer's when we really have no idea how to treat it. And nothing that we've done medication-wise has shown any impact upon slowing down the onset of Alzheimer's progression. We do know the association of APOE with Alzheimer's, but so far, even though we know about these bacterial associations, how they really decrease the likelihood of Alzheimer's remains unclear.
Dr. Callender kind of reminds me of HIV when they couldn't figure out what was going on with HIV.
Yeah, it took us a while, didn't it? But we finally got it. So I guess we need to be patient as we continue to look. Let's go to the next one. I'm gonna have to make this the last one. This is an interesting test, speech test, that could help have you talk into this apparatus, and the apparatus will tell you whether it looks at your parietal lobe and see how your temporal lobe and see how it responds, and based upon that, they would make the diagnosis of Alzheimer's. But it hasn't been. It's not something that's widely used. This is something that may well be in the future. So you can have a distant test to find out whether you have Alzheimer's or not. To me, its value is only in being able to get the family to be supportive and helpful in those people who have dementia. I think this will have to be the last article. It's 10:30. And any other comments you want to make before we close? Lucia, we asked you about how we're going to help with gender harassment for female doctors. You have any ideas, any clues as to how to solve that problem? I'm sure you experienced it. What do we
Am
do for
I
your
going to
daughter?
get the $365,000 when I answer the question?
Only if you answer it correctly.
It's a big issue.
Yeah.
And it's, as we've heard through many of the articles, it's a gender bias. And like I didn't realize when I started with my HIV care that it was an issue associated with power. And I say that from the sexual context. I thought it was power over sex. And that issue, the biases, the presuppositions, all of the things that physicians bring into medicine need to be addressed in the art of the practice of medicine. And therefore, I think when there is a physician, and I always sing your praises, like you, that raise the bar, then it becomes it becomes something that you now have seen exhibited, and then you do the same. So go ahead.
Is that helped by having more women in medicine?
I think it gives a group, but I think so much has to happen with the men in leadership in medicine. So seeing someone that you have respect for from an academic basis, and you then see how they model their behavior before you to women, I think that probably has a very significant impact.
How about the glass ceiling for women in medicine? How do you address that? I think your answer is a great one, but how about the glass ceiling in medicine for women?
Again, I think the example of having a man of authority, step aside and see the accomplishments of a woman, and they make the first poke, and then it's done. It's done. Like I would have, and it doesn't have to do with medicine, but if male university presidents stood up for the female presidents at Ivy League institutions around the issue of Gaza and Israel, that would have been a major statement.
What does that have to do with gender harassment?
Because these women, and I wish I had the names in front of me, the Black one at Harvard was the first. So if a white male college president was to come out with a statement or now tweet in support of her, I think that would have done a lot to validate her posture as it related to the policies of the university. So it's not direct, but the validation is another poke into the glass ceiling, because they're women that are prepared. The avenue isn't there.
So the opportunity is a major factor, just with ethnicity. It's not that they can't do it, it's just that they don't have the opportunity to do it. Any other comments you want to make before we close our session today? Lucian?